Hi, my name is Mary Beth Terry, and on behalf of our entire planning committee, I wanted to thank everyone for joining this webinar. We recognize these are very difficult times for our communities. COVID-19 is just one of so many health inequities existing in the US. Smoking and smoking-related diseases are yet another. It is important that we emphasize that health inequities are not just health disparities. Health inequities are not only unnecessary and avoidable, but are also unfair and unjust. And what communities of color are experiencing with health inequities is related to the systematic racism that continues to exist in the United States. By holding this webinar tonight, we do not wish to convey that business is as usual, but rather we decided to continue to hold this webinar in recognition and special thanks to Senator Jackson, who has graciously agreed to kick off this New York City-wide World No Tobacco Week. And in recognition to everyone who's joining the webinar and is listening to the recording. And in recognition to our esteemed set of panelists who you'll meet in just a few minutes, and in recognition of the entire planning team across New York City in planning these events. Senator Robert Jackson has taken on difficult fights on behalf of New Yorkers and never backed down. In his first elected position as school board president, where he launched the Campaign for Fiscal Equity school funding lawsuit, he walked 150 miles to Albany to highlight the cause and won a court judgment that awarded $16 billion to New York City public schools. In his 12 years on the city council, where he sponsored the Small Business Jobs Survival Act and fought for justice and equality, and now as a state senator, he's championing public education, workers' rights, climate justice, gun safety, healthcare for all, and more. He knows how to get things done and has the record to prove it. Born and raised in Manhattan, Robert and his family have lived in Washington Heights since 1975. He attended New York City public schools and graduated from State University of New York in New Paltz. And Senator Jackson is doing so much for cancer prevention and has worked very closely with all of our cancer centers as well as the American Cancer Society. And we really are so grateful for all the work he does for cancer prevention and cancer screening. We're also grateful for all the work that he does for our communities, and he held a vigil yesterday in Upper Manhattan, and we were hoping in order to kick off this New York City World No Tobacco Week, he could also lead us in a moment of silence.
So let me say to all of you that it's important that you think about the situations that we're dealing with today. And I ask you to take a minute of silence to think about all of the people that have perished as a result of cancer, smoking, and about all of the conditions that exist in our country and our world. So with that, I'm going to raise my hand as I did yesterday when we closed. We said, if you had a sign, raise your sign. And here's my invisible sign. Smoking kills. Thank you. So good evening, everyone. My name is Robert Jackson. I'm the state senator that represents 13 miles of Manhattan from Marble Hill all the way down to 26th Street and 9th Avenue. It's about 330,000 people and about 45% Caucasian, in essence white, and about 40% Latinx from Latin people from all over the world, and about 12% Black. But in the most northern part of my district, in my opinion, that's where we have the most health disparities. And I'm so happy to be here speaking to all of you, because you are the experts, you are the people that are dealing with the issue of smoking and cancer more so than I am. I say that one of the things I communicate with people all the time is make sure that you know and get a health exam at least once a year. And I've said to people that your body is a human machine, And if you listen to it, it will tell you sometimes, or most of the time, when you have a problem. It's just, you have to be able to listen to it. It tells you. I remember once when I was with, at that time, City Council member Bill Perkins. And we were at Harlem Hospital at a press conference about colon cancer. And he spoke, and what he was pretty blunt and straightforward. His advice was, get your butt checked. And so after that, I said to a reporter of the Amsterdam News that I will have a colonoscopy done. And he said to me, then I will follow you on that. Press conference was over. A month, 2 months, 3 months, 6 months has passed, almost 9 months. And he called me up, he said, excuse me, Mr. Jackson, you said that you were going to have a colonoscopy. How come? I'm sorry, I don't have any symptoms. Well, you know, as doctors and as experts, that really, sometimes you don't have any symptoms until it's too late. And so I did have a colonoscopy back then, and it came out negative. So that was a good thing. But I've committed that I need to have another one, even though they have the, the colon guard, where that you can send in your feces to determine what have you and so forth. And then obviously, when I take my blood work, so I know my doctor's telling me everything as far as my blood work is okay, which is very, very important. But let me just say this to you. I'm so happy in knowing that this is the first webinar and about the topic that is so important to all of us right now, and that intersection of smoking and COVID-19. And I understand that the future ones is people are vaping and smoking. What do physicians say, and what does it mean for all of us? And then the third webinar is very good, excellent. Secondhand smoke. Are the droplets traveling further than the smoke? These are things that we all need to know, in my opinion. But myself, as an individual, I do not smoke at all. But I understand the struggles that it can be if you smoke to try to quit. Because I've had friends and families. And in fact, my mother and my dad's, they are deceased now. But I know that my mother smoked most of her life. And my dad's, one died at 93 and he smoked up until he died. And one died at 86, 87, and he smoked also. But I look at my siblings, my brothers and sisters, and most of us did not smoke. My wife doesn't smoke. And the environment in our home where our children observe us not smoking, they don't smoke. And they're now 45, 39, and 33. And that's a good thing. And that's the type of positive example that you want to set for not only your family, but friends also. And because we have a home and we don't have ashtrays in our home because no one smokes. And if someone comes to our home that wants to smoke, we ask them to please go outside. Please don't smoke in our home, because that smoke gets in your clothes, all in your furniture and everything like that. But I can imagine that how hard it is to quit smoking when there are so many added stresses in your lives because of this pandemic. For so many people who smoke, they continue to do so because it provides comfort. And others right now, people that have lost their jobs, that are thinking about how are they going to pay their rent or their mortgage, or how are they going to pay their school bills for their children if they have children, or how are they going to get food to eat? I mean, if you live anywhere in the country, you have seen the long lines for food banks and things like that. And I know that the federal government and the state government and the city is talking about dealing with the rent burden that people cannot pay the rent. There are so many stresses now that the last type of thing they want is to think about all of the problems that they have. But that's why it's important that we stay healthy, that we get rest, that we drink a lot of water, that we exercise, and just think positive. Positive thinking is so, so, so important. So I'm also glad to know that screening will be discussed on this program tonight. And I'm a big supporter of regular health screening, especially these common type of cancers. And I've said to people that for me, I used to go, every time I go for my doctor's appointment, I told him I want to have an HIV test. And he said, why is that? I said, I know what my status is, but I want to make sure. So everyone should know their status as far as their health is concerned. And if you know anything about COVID-19, they talk about the respiratory system and how it impacts your breathing and all of the things relating to that. So a relative of mine, we believe he had a mild case where he was not hospitalized. And do you know he recovered? And I took him for a test through a drive-through up in the Bronx, and it came back negative. Great. But do you know, even a week or 2 or 3 after, he said he's still, and he's a marathon runner. Mind you, he's run over a dozen marathons. He says that he still feels a little tired walking up the stairs. But my understanding, that is symptomatic of people who have had COVID-19. So providing these services that you're going to talk about today is especially important for people of color. You may say, wait a minute, isn't it important for everyone? Of course it is. But people of color have the most type of serious underlying conditions, asthma, high blood pressure, and all the other things that come with that, diabetes, and because of poor eating and all of that. So it's important that they listen to you as experts in the field, how to improve their lives by not smoking. Also to improve their lives by making sure that they get their butt checked, as Bill Perkins would say, to make sure that you're healthy and clean. And so with that, I want to say that I held a hearing on May 18th. It was a 12-hour hearing, a joint hearing between the New York State Senate and the New York State Assembly. And the theme of that hearing was exploring solutions to the disproportionate impact of COVID-19 on minorities communities. And we've had, I think, 9 different panels with experts in the field, community-based organizations, and what have you, that gave their input on suggestions. It's important to know that we all must come together, united as one, to address these issues and concerns. And so with that, I thank you for giving me the opportunity to come in front of you. I'm an advocate for good health. I've run 3 New York City marathons, but the last one I ran was about 10 years ago, but I need to get out there again. And my goal is to run 3 hours and 30 minutes. And I will be at that time, if I do it this year, I'm 69 years young. So with that, I say to all of the groups and organizations from all of the medical centers involved and the doctors and the community-based organizations that I saw many of them listed in your program, and I know a lot of them. So do the right thing, continue to focus on the people that we serve, understanding that we're all going to improve our health and welfare of everyone. Thank you very much for having me this evening. I plan on leaving, but I may be joining back this evening as part of the program. Thank you.
Well, thank you so much, Senator Jackson, and thank you for your service and for all that you do for our communities. And we really appreciate it. We know you have so many things to do still tonight, but thank you so much.
Thank you.
Great. All right, thank you. And now we'll hear from Kimberly Burke, who will tell us about the a panel discussion and how it will run tonight, as well as introduce the whole week to us.
Yes, thank you, Mary Beth. So I'm speaking to you. I work for the Columbia Cancer Center, and our group, along with the other New York City Cancer Centers and New York City Smokefree, we've come together to put on this week event, which is called NYC No Tobacco Week, which starts on May 31st, World No Tobacco Week. And we have events going this whole week. And so this is our kickoff webinar, COVID-19 and smoking. Our groups have been working together to share data, to look at health disparities and inequities surrounding cancer across the 5 boroughs. And this is our big event that the New York City Cancer Centers have never done this type of event before. So it's our first event, and we're looking forward to doing more in the future. We also want to thank the community organizations who helped to co-sponsor this event. We Act for Environmental Justice, Rise Borough, Hispanic Federation, Union Settlement, Arab American Family Support Center, Chinese American Planning Council, Harlem Congregations for Community Improvement, Ventanilla de Salud at the Mexican Consulate, and Columbia Center for Children's Environmental Health. And we have a series of panelists tonight. We're going to start with Dr. Brendon Stiles, who is a thoracic surgeon at Weill Cornell Medicine and New York Presbyterian Hospital. And I'm going to ask Dr. Stiles to begin with us in a moment. And just before I start, I want to ask every attendee to just look at the bottom of your screen. There is a little box that says Q&A. You can type questions into that box, and we'll be monitoring that, and we will be answering about 1 or 2 questions after each presenter, and then we'll have a full question and answer session at the end that will run for about 45 minutes, and we'll address all your other questions there. So we have about 4 panelists that will be speaking, and we'll be taking a few questions after each. So Brendon Stiles, please commence your presentation. Thank you.
Hi, thanks so much for having me. I'm going to share my screen here for everybody to see. I'm thrilled to be here, and probably even more particular, I'm thrilled that I'm hopefully thrilled that I'm going to be sharing my screen. I'm thrilled that all the cancer centers are coming together really in this partnership. I really do think it's so important. And you can see how important it was when the city fought COVID, and I think it's just as important for longer term projects on fighting cancer, on overcoming tobacco addiction, and on moving forward as a whole. I'm a thoracic surgeon, you heard, but I'm also chair of the Lung Cancer Research Foundation, and I'm an active member of things like the National Lung Cancer Roundtable, and then ISLC, groups that are very interested not just in treatment of cancer, but really in prevention of cancer, tobacco cessation, and overcoming disparities of care, which we all recognize is a huge issue. I'm tasked a bit with talking a little bit about how COVID affects your respiratory health, and I think it is an interesting question. This is a great piece from the New England Journal of Medicine from some of our physicians here that really tried to put it in context of how does COVID affect patients. You can see that dyspnea, which really means shortness of breath, happens in about 40% of symptomatic patients. So if you get COVID, there's a high likelihood that you're going to get short of breath. And we've all heard the stories about how patients presented that way. Of those, about 5% will have critical illness, and that means on a ventilator. All of us at these New York City institutions that you see represented saw this, and the staggering number of patients who are on ventilators. I think we peaked at over 220 here at Cornell when we have a usual census of about 50 to 60 on ventilators. It truly is a respiratory disease, and that was something that we learned pretty quickly. COVID can affect a lot of different things, and if you look at this little graphic that was in this great paper, it almost looks like smoking, right? It causes problems in the lungs, it causes thrombosis, it causes problems in the blood vessels. But we know that COVID can damage the lining of the air sacs in the lungs where oxygen is delivered to the blood. And those sacs start to fill up with fluid, dead cells, and debris, and then they prevent oxygen from getting through. And that's why so many patients presented with such profoundly low oxygen. And this is a picture of the little capillaries in the lungs just filled with inflammatory cells, or inflammatory cells filling the underlying lining of the lung. And the real manifestation of that looks something like this. On the left here, these are patients who presented, and then they were coming back, but were still asymptomatic and got a repeat CT scan. And that filling of the air sac with lungs is what these little white spots look like in the CT scan. And again, these are relatively asymptomatic patients. But it can present all the way to this. And this is a 28-year-old guy who was healthy, who now has his lungs essentially destroyed by COVID. And that's just one of the many remarkable courses that I've seen like that here at the hospital. The big question, though, and one that's caught a lot of news, is how does smoking play in? If you already smoke and you've already exposed your lungs to inflammation, how will that impact you if you get COVID-19? And surprisingly, the jury on that is still a bit out, and there's little data on both sides that I'll talk about. This is basically what's called a pooled analysis of several different studies, most from China. And then at the bottom, they put them all together. And so if you get more sick, if you're a smoker and have COVID, it's to the right, less sick to the left. You can see that the majority of studies are to the right, and that it actually ends up that they had a 90% higher chance of having disease progression if you were a smoker with COVID. Progression can be defined a lot of different ways, and sometimes in some of these studies it meant more oxygen, sometimes it meant ventilator, sometimes it meant ICU. But the general consensus here was that if you were a smoker and got COVID, you were likely to get sicker. Now, there's also been a lot in the news, though, that almost argues the opposite. And you can see when something hits the popular press, like The Economist, obviously people are paying a lot of attention. But that's this idea that nicotine could potentially be protective of infection. And there was some data from China and France that suggested lower than expected rates of hospitalization for smokers. And that's really where a lot of it came from. Places like China, where some places there was a 50% incidence of smoking in the male population, but only 5 to 10% of admitted patients with COVID were smokers, raised the question of, is smoking somehow protective? And there may be some biologically plausible pathways for that. Tobacco smoke can change the receptor, an ACE2 receptor, which is active in the lung and in blood vessels. And there's been literature both ways saying that can be good and that can be bad. But I think the jury is still out, and certainly none of us here would recommend people for nicotine replacement, although it's been advanced in some trials, and I think that's the proper scenario to better test it out. Certainly none of us would advocate for smoking in this situation. And that's because robust evidence suggests that smoking increases the risk of respiratory tract infections. We know that. We know that smoking impairs your immune function. And again, as I'd mentioned, current and past smokers had worse outcomes when infected with COVID. Smoking is also obviously associated with hypertension and diabetes, both of which were associated with infection and worse outcomes in COVID patients. And just if you imagine just the general habits of smokers, putting things in your mouth, touching, sharing, bringing things to your face is obviously problematic in the era of COVID. Now, what about vaping? I think a lot of us who think about tobacco cessation have to make an opinion on whether vaping and electronic cigarettes are good or bad. They certainly can help some people quit smoking, quit tobacco smoking, which we think may have some benefits. But the question is, how long do they quit for? And probably an even more alarming question is vaping going to be a bridge towards increased numbers of smokers? And you've all probably seen some of this data that shows the staggering increase in smoking rates among high schoolers, higher e-cigarette use, higher use of e-cigarettes with nicotine, leading to really a pandemic where we've seen staggering numbers of teens potentially addicted to nicotine. Now, if you all take a step back in time, which I know with all the things going on in the world is hard to do, the last big respiratory event before COVID was this thing called E-Valley, which was the e-cigarette and vaping associated lung injury back in the fall to the end of the summer. And really that was taking off. We heard of all these cases of this acute lung injury, often in very young, healthy people. Sounds similar to COVID in many ways, where patients were getting sick, hospitalized, some even needing transplants. And a lot of it obviously depended upon the makeup of what they were vaping, and likely or probably related to vitamin E acetate, but still a pretty staggering effect of that, that phenomenon just as an acute effect from vaping. Probably more significantly are the long-term effects of vaping. I think it's commonly suggested that it's a free pass, that you don't have to smoke tobacco, so it's not carcinogenic. But increasingly, we're seeing studies in the literature that suggest that this inflammation, this inhaled substances may be carcinogenic. And these are just studying cells in people's mouths, and they looked at signatures in smokers and signatures in e-cigarette users, healthy young people. And they found there was significant overlap between the gene expression changes. And not surprisingly, the most common pathways that were altered were cancer, injury, and abnormalities. Certainly very, very concerning data. We have some folks from NYU on the line too. There was a great study from NYU last year that also suggested that just vaping daily in mice could cause cancer. So clearly, I think we don't know enough about this yet, and clearly the potential is out there for this, both as a bridge to smoking, but also as a carcinogenic effect on its own. So that's a good time, I think, to pivot for screening for lung cancer. The senator mentioned screening, and he talked about it in a little bit in the context. An obvious question is why screen for lung cancer? And I think the answer is equally obvious, because it's a very common cancer, the second most common cancer in men, second most common cancer in women. But probably more importantly, it's a very deadly cancer. It kills more patients than breast, prostate, and colon cancer combined. Senator Jackson said your body can tell you what's wrong, but the idea behind screening is it really, if your body is telling you have lung cancer, it's probably too late. Screening will catch it earlier, we hope, when we can still act upon it before it affects your body. And we have good data for lung cancer screening. This is a study called the National Lung Screening Trial, and it showed a 20% reduction of dying from lung cancer in patients who are screened with a simple CT scan. Almost a 7% reduction in dying from any cause. And so it's approved. You can get it through your insurance, you can get it through Medicare. It's also supported by a recent study called the Nelson trial in Europe that suggested, again, a 26% mortality in men and maybe even higher in women, 61% mortality. And almost all these patients were smokers who had lung cancer deaths prevented by getting a simple CT scan. So who's eligible? If you're 55 to 76 or up to 80 years old, if you've smoked or currently smoke, if you've smoked up to 30 pack years, so 1 pack a day for 30 years. And then there's a lot of other secondary parts of the risk assessment that include radon exposure, cancer history, family history, and exposure to secondhand smoke. It's important that this is a shared decision-making where you actually go and you talk to somebody about the risks and benefits of screening. You talk about false positives. What if you found it to have a nodule? And are there any harms to screening? There's been a lot of attention played to the harms, and I think that's really hurt the efforts for lung cancer screening. There's guides like this that say 3 in 1,000 fewer died from lung cancer, but 2 in 1,000 had a major complication. Simply not true the way that the math is done. If you take out the patients who ended up having lung cancer and had complications that were probably also related to the lung cancer, that number really becomes 4 in 10,000 patients not found to have a cancer will have a major complication. And you can see out of 25,000 patients, very, very few major events, and often not related to just getting a CT scan. So why should we screen? Again, I'll tell you, these are rates of screening and potential lives saved by 2030 if we screen for lung cancer. Right now, believe it or not, the rate of screening for lung cancer is less than 10% of eligible patients. If we got it up to these numbers, which are very achievable with every other major cancer that we screen for, we could save over 100,000 lives by 2030 if we got our rates of screening higher. So lung cancer screening is very important. It's especially important that we reach it to the communities at risk who perhaps aren't as aware, aren't as plugged into the healthcare system. We know that we can save lives in that setting. I'll just close with this. I think, one light that we might get out of this, out of COVID, was this was a question, a poll that was done by a group called the Foundation for a Smoke-Free World, and they asked patients, does the COVID outbreak affect your desire to quit smoking or vaping for health reasons? And you can see different countries, India, the UK, the US here. And interestingly, they broke it down by if you had a family member or somebody you knew with COVID, what was your likelihood? And you can see if you lived in the United States and you knew somebody with COVID, you were 83% of those people wanted to try to quit and try to affect the change. There's never been a better time, I think, to have this discussion. Lung health is on people's mind. People are scared of lung problems and scared of the potential effect of smoking and COVID. And so I commend and I thank all the organizers of the talk for inviting me. And I'm happy to take questions at the end, and I'm really looking forward to hearing the rest of the panelists.
Wonderful. Thank you so much, Dr. Stiles. If you do have a question, please put it in the chat room and we can ask it of Dr. Stiles. Dr. Stiles, can I read you one question that someone wrote in for before the seminar? If you have a lung-related health condition, how can COVID exacerbate it? And what should you do? So this person specifically wanted to know about cancers, but if you could talk in general what they should do.
Sure, it's a great question. There's also been lots of data about patients with cancer being more at risk for COVID or for severe complications from COVID. And we know that that's probably the case. I think the issue with all of these things is trying to adjust for other risk factors to see how much is just related to the cancer, how much is just related to smoking, or whether it's a combination of all things. But I think what we've found out is that there really is a very narrow window. If you already have problems with your lungs, if you already have an underlying health problem, then you're really at risk of getting really sick if you get COVID. And so those patients should take everything that we're talking about distancing, about protection, about hand washing much more seriously.
Thank you. And if you wouldn't mind answering one more question, and then we'll move to the next speaker.
Sure.
The question says, someone that is 68 years old that was diagnosed with breast cancer 2 years ago and gave up smoking 35 years ago, should they be screened for lung cancer now?
That's a challenging question. They wouldn't actually fit lung cancer screening criteria, but we know that about a third of the patients, or 2/3 of the patients actually that we operate on, often wouldn't fit screening criteria. It's often related to age or when people stop smoking. It's a worthwhile conversation to have with your own doctor and to really talk about some of the nuances about secondary risk factors. As long as people are intelligent about screening, I think it can be done well and safely.
Great, thank you so much.
Okay, we're going to move on. Thank you so much, Brendon. That was so informative. We're going to move on to our next panelist, who is Deidre Sully, the director of New York City Smokefree. And Deidre is going to be telling us about why advocacy surrounding smoke-free protections in New York City is more important than ever right now. So Deidre, are you ready to share your screen?
Yes, I am. Let me see if I can do this properly. Can you see?
Yes, we can see.
Okay. All right, so thank you for having me. As Kim said, my name is Deidre Sully. I'm the director of NYC Smokefree. And what we do is tobacco control advocacy in New York City. We're a program of public health solutions, and we've been around for the better part of 20 years. And we pretty much try to make that we're staying within the zeitgeist of tobacco control and monitoring health disparities and how that relates to tobacco disparities in New York City. So I don't want to get too much into the particulars of vaping. I think we heard some of that, and I think we'll get some of that from some of the other presenters. But I do want to just reiterate, we do some of the facts, and we do know that smoking and vaping, can lead to compromised lung function. And we also know now that those things are also risk factors for COVID-19. How that relates to tobacco advocacy is making sure, part of our job is making sure that we're doing a lot of the education at the community level with both adults, influential people, especially young people, and making sure that people understand the dangers thereof and the particulars that come with those dangers and some of the nuances. One of those being flavors. And I'll take you through really quickly. We've recently had some wins in restriction on flavors. So just recently, New York State's flavor ban went into effect on May 18th. And New York City is not far behind. On July 1st, the flavor ban, that's a typo, yay. Flavor ban will go into effect on July 1st. And those flavor bans are important because it includes all flavored e-cigs, and they did include menthol in those e-cigs, mint and wintergreen and menthol flavors. We do still have some work to do in our state and in the city, where we have to make sure that we're doing a lot of the education and making sure that people know the dangers of menthol with traditional tobacco products such as combustibles. One great win today was in Massachusetts. They passed their flavor ban today, and it actually included mint and menthol and combustibles, and I believe they're actually the first state to go that far. And so I want to just go a little bit deeper into why flavors and paying attention to that is really important. And it's because flavors hook kids, plain and simple. That is the initiating thing that gets young people to start smoking, whether it is use of e-cigarettes and vaping or combustibles. And one of the main flavors is mint and menthol. Yes, we know that the fruity flavors for the e-cigs were the most popular, but the second runner-up was mint, and menthol is a part of that. Menthol is a derivative of the mint plant, and the reason why it's used in tobacco products is because it gives a very false sense of safe smoking, where it numbs the throat because of the cooling sensation that mint has, And so it masks the actual harshness of the tobacco going down. And so when you are a new smoker, or which is usually a younger person, it helps to initiate that person or the young person into smoking. And the problem with that is that it makes it very, very difficult to quit. We already know that tobacco use is an addiction, and the addition of a flavor like menthol makes it even that much harder for people to quit. So one way that we at NYC Smoke Free at Public Health Solutions are really trying to combat that is through media. And so we currently have a media campaign going on to help to educate the public about this issue, because as I said, more work needs to be done. We've had a lot of great wins over the last couple of months and couple of years when it comes to tobacco control, but there's always something that needs to be done because we have an enemy that is very crafty. Big tobacco always has something up their sleeve. So I just want to give you an example of the campaign that we're running right now. And this is very, very important because, as I said, menthol is the initiating flavor. But one of the more things that is sinister about menthol is that it actually, more Black people use menthol. So Black smokers, people who smoke that are Black, they use menthol at a rate of 85%, a little over 85%. And this is not a mistake. This is very much on purpose. And a lot of this comes from marketing tactics. And we know that that is the same tactics used when we're talking about e-cigs. So marketing is a very, very important tool that the tobacco industry uses to sell their product, obviously. One thing we want people to know is that, though, this product, when used properly, it most likely will kill you or make you sick. So it's really important to get out the message about menthol and its effect on young people and people of color, specifically people in the African American community. And especially as right now, when we're seeing the effects and the disparities and public health disparities of COVID, and people of color are dying at higher rates, what's happening to those people who are smokers? So it's really important that people have the facts and have some understanding and some awareness of the importance of knowing why flavors in tobacco are a danger, and particularly menthol. That being said, we are also running another campaign to keep people informed about what's going on in tobacco. And this is really important because as phrases like shelter in place and social distancing become part of our everyday vocabulary and our everyday language, things like issues like smoke-free housing really need to be brought to the forefront. So smoke-free housing and increasing the amount of units in New York City that are smoke-free is part of part of our work. And we, move through New York City in all 5 boroughs to work with landlords, property owners, sometimes tenants, to really give them information and help them bring their buildings smoke-free. This has now more than ever become something that's moving to the forefront because people are now in their homes more. Before, people are out at work, and something like smoke-free housing may not seem like it bothers you that much. But when now we're sheltered in place and we're kind of on a lockdown and mandated, to our apartments and there's really nowhere to go, people are really noticing how much shared air that they're using with their neighbors, and how a neighbor that smokes or chain smokes can really affect your family negatively. We know that people are at home. Some people have lost jobs. One thing they don't need is medical because they've now been exposed to secondhand or thirdhand smoke from someone that lives in their building. So we are definitely running this campaign to educate people on the need and the importance of smoke-free housing. I put a little description on the screen, hopefully that you can see it, of the ad that's running. Maybe you've seen it over your Instagram or Facebook or Twitter, because we want to make sure that we're getting to people where they are. And as we're all home, we know that people are on their computers, on their phones. So this is, we thought that this was a really good medium to reach people in that way, in a really big way. And also just an example of some of the feedback that we get even on Twitter when it comes to our campaign. It's really striking a chord with people as is the menthol as well. People are really noticing, as I said, how staying at home and sheltering in place really affects their health and how they're exposed to tobacco smoke. And that's really the same as it goes when we're talking about social distancing. As we're looking at states in New York City, you know, talking about reopening and people moving around again, we see that there are a lot of instances where people are waiting for food in bars and restaurants that are, you know, kind of semi-open or at least allowing takeout. And especially as the weather is getting warmer, we've been cooped up for most of 2020, and people want to get out. So what happens when you have people who are addicted, they use tobacco and they are addicted, and everybody's out on the street? What happens when we're trying to social distance and they're smoking, and people are now being exposed to secondhand smoke? So one thing we want to make sure that we're doing is continuing to work with community organizations and things like bids and businesses in New York City to show them how important it is to establish tobacco-free outdoor air policies for their businesses. And we know in New York City, that is a very, really big feat because, you know, space is at a premium. So your outdoor space may just be your front door. So that's why it's important to talk to all of these places and make sure that they all understand and there's an agreement. You know, one thing that we've all been saying through this is that we're all in this together. So we should all be in this together and make sure that we are eliminating secondhand smoke and making sure that we have people's public health at the forefront. And I just wanted to, and so my presentation was very quick, I just wanted to share this with you as like an example. So this is an article from Eater over the weekend when we had that really warm weekend, and you can see how people are very clustered, like social distancing becomes like a, what's that? So we want to make sure that, you know, as people are, you know, trying to come back out and social distancing or not, that they are at least not having to be inundated and bothered with secondhand smoke. So in a nutshell, that is NYC Smoke-Free. You know, tobacco advocacy, especially in the time of COVID, is really, really important because it's bringing a lot of things to the forefront. And we want to make sure that people's public health is number one.
Thank you so much for that outstanding presentation. And thank you so much for all your help, Deidre, in planning everything. There's a few comments in the chat room, and please do send in some more questions if you have them. One question says, thank you so much for this presentation, Ms. Sully. On average, what age do African Americans start using menthol? What can we do and or can be done to prevent the population from being attracted to menthol?
So on average, and I will give a general, it's really young people, regardless of race. The average age of smoking in New York State, smoking initiation is 13. Okay. And so one of the issues around menthol, a lot of people will say, well, I started smoking because my mom smoked or my dad smoked menthols or my aunt smoked menthols. But one thing that we know that's a fact, the tobacco industry has a sordid history of marketing in Black communities, you know, using celebrities, very much of the same tactics that they do now, sponsoring shows. One very sinister thing is really infiltrating historically Black organizations such as civic organizations, schools, and the like, you know, paying for buildings and things like that in an effort to, you know, make sure that they have an ally in the Black community. So it's really is initiation is kind of general with, you know, 13 being the age in New York City, but there at some point, yes, there is a kind of a break off where Black people will continue to smoke menthol.
Great. One person wanted to help volunteer. I'm sure there's many other people on the webinar who would love to volunteer. So would they contact you directly at this email, I assume?
Yes.
Okay, perfect. And then can you say the two remaining questions and then we'll move on. But again, we're going to have a question and answer period at the end. Can you say a little bit more about secondhand smoke, and does that include vaping, and what can be done to help children from vaping?
So right now, I don't believe there's any data. Maybe one of the other panelists may have something to say about this on secondhand vaping. Right now, a lot of our education is talking about how dangerous it is to the actual person that's using, because we know that there are different chemicals, just like there's chemicals in combustibles, there's chemicals that can really harm the lung. You know, truthfully, we shouldn't be inhaling anything but oxygen. So, so I don't have like any information on secondhand vaping, but as studies are going, I'm sure we will have some information. You know, the jury is still out on whether e-cigarettes and vaping is harmful or harm reduction. But as tobacco advocacy and public health person, you know, it's important that we err on the side of caution, because we do know the history of, you know, tobacco was marketed by doctors and nurses a lot of the times. And then 50 years later, we had the Surgeon General's report, you know, revealing that it actually is bad for you. So we don't want to have another incident like that.
Great. And maybe then in the question and answer period, we can talk a little bit more about school children. But thank you so much for that presentation. That was fantastic.
Thanks.
Thank you so much, Deidre. That was wonderful. So next, we will be moving to Dr. David Albert, who is with an MPH and dental degree. He works in community health at Columbia College of Dental Medicine. And he's going to, let's see, Dr. Albert, are you ready to share your screen? Thank you.
One sec. Trying to do slideshow, it's not working. Second, there we go.
Wonderful.
We have it. Okay. So I direct the New York Presbyterian Hospital tobacco cessation program that we have funded from the New York State Performing Provider System Tobacco Cessation Program. I'm also the co-project lead of the C3I Moonshot Initiative from NCI at the Herbert Irving Comprehensive Cancer Center. And a big feature of that program is implementing tobacco cessation counseling and services for cancer patients. Much of that was done on the telephone, and now because of COVID-19, we're shifting almost all of our interventions with patients into telehealth video conferencing, as well as telephone conferencing. And that technology is really exceptional, especially for cancer patients who have complicated lives, are coming in for a variety of different types of therapy, being able to communicate with a nurse or a community health worker to stop smoking is really, really exceptional. Some of the things I'm going to cover are actually things that Dr. Stiles and Deidre Sully talked about already, so I'm going to skip quickly through it. But I just want to mention this ACE2 receptor that Dr. Stiles mentioned, that can be implicated in a negative way, but perhaps a positive way. It is also, this ACE2 receptor is a known receptor for COVID-19 and other respiratory illnesses. The CDC, the Centers for Disease Control and Prevention, declared an outbreak of the e-cigarette vaping product use associated lung injury, EVALI. And I think that that's important because that was the first time last year when that came out. And again, what Dr. Stiles said, our memory of what happened last year is kind of faded. But this was the first time that young adults actually started to hear some negative things about vaping. The marketing of vaping products has been overwhelmingly positive. The way it's been presented in the media was overwhelmingly positive. And this was the first time where we started to see some really, really significant respiratory illnesses, and none of this was being reported prior to that. It remains to be seen whether the current COVID crisis has resulted in younger adults ceasing to use or cutting back on vaping products. But there'll be more about this in my last slide about the availability of vaping products. Okay, so severe coronavirus disease is characterized by respiratory distress and decreased oxygen saturation, So vaping and smoking are both things that are going to cause respiratory decline. I'm sorry. Okay, so the Moonshot program that I mentioned was initiated by Vice President Biden, and the component that we have in the C3I program is to help oncology patients stop smoking. Continued smoking after cancer diagnosis increases post-treatment mortality, the risk of cancer recurrence, and side effects from cancer treatment. So quitting smoking after cancer diagnosis is associated with longer survival and reduced risk of new cancers. It's very difficult often, though, with cancer survivors and cancer patients who are going through diagnosis and treatment and surgery to get them to move forward with trying to quit. But it's still an important thing that we need to do, and those services are essential and should be pushed at every opportunity for cancer patients. The National Comprehensive Cancer Network has set up, this otherwise known as NCCN, has set up guidelines for tobacco cessation programs for cancer patients. So on this slide, just want to go through 40% of cancers diagnosed in the US have a link to tobacco use, particularly those of the mouth, the lip, the nose, sinuses, larynx, pharynx, esophagus, stomach, pancreas, kidney, bladder, uterus, cervix, colon, rectum, ovary, and myeloid leukemia. In 2009 to 2013, in each year, 666,000 people diagnosed with and 343,000 people died from cancer related to tobacco illness. So smoking is the most important thing that we have to cut back on to prevent cancer, but then when cancer is diagnosed, to remove smoking from the patient's armamentarium, so to speak. So incident rates from tobacco-related cancers are higher among men than women. So the effect of cigarette smoke on cancer cells and established tumors: increased cell proliferation following cigarette smoking component exposure has been seen in esophageal, breast, and lung cancer cells. Cigarette smoke can induce migration in cancer cells, so we worry about the cancers migrating elsewhere in the body. Incubation with cigarette components results in increased cell migration in several human cell lines, including colon, prostate, gastric, breast, and ovarian cancer cell. So the United States Public Health Service set up in 2000 something called the 5 A's. And this is the core of what we're doing in the C3I program at the Herbert Irving Cancer Center, as well as at all the other cancer centers in this network. And that consists of ask, advise, assess, assist, and arrange. So asking all our patients, do you smoke? Advising patients to quit. Talking about health-related findings. Assessing the readiness of an individual to quit, because not everyone is interested in quitting, but letting the patients know that we have the services available to help them quit. Assisting with setting a quit date, discussing pharmacotherapy, providing materials, and arranging follow-up at the patient's next visit. I want to just focus, though, on pharmacotherapy. Pharmacotherapy is essential. It is a very important component, and it's a feature of the National Comprehensive Cancer Network program. Self-quitting, people who just, the New Year's resolution, I'm going to quit, 5%. You've been diagnosed with a cancer, and the physician tells you it's very important, you have lung cancer, you should quit. We double the quit rate to 10%, but that's not enough. Group counseling can improve the amount of quitting, but writing prescriptions is remarkable. Writing prescriptions increases twofold the amount of quits that we get. Providing counseling plus nicotine replacement therapy or counseling plus non-nicotine medications remarkably improves quits or harm reduction, reducing the amount of tobacco consumed by the patient. So we have in nicotine replacement therapy 5 products, 3 of which are over-the-counter, OTC on this list, patch, gum, and lozenge. And then we have a couple of prescription medications, oral inhaler and nasal spray. And then we have non-nicotine medications, varenicline, also known as Chantix, and bupropion, which is an antidepressant, which is known as Wellbutrin, or packaged exactly the same medication as Zyban, as an anti-smoking medication. Just back to this, I'm sorry. I just want to mention that all of these products in any of the Affordable Care Act insurance programs are covered. Medicare will cover varenicline, and Medicare will also cover the nasal spray. New York State's Medicaid program is a fantastic program when it comes to tobacco cessation medications. All of these medications are covered in the New York State Medicaid program. Okay. And I want to finish with this slide on vaping during the COVID-19 pandemic, and actually hit upon some of the things that Deidre Sully mentioned as well. This banning of the use of menthol, banning of flavored products is so important. And hopefully State Senator Robert Jackson's back on, really commend the state in banning flavored vaping products. But we need to push the state to do what Massachusetts has just done and ban menthol products. Menthol products, combustible products, are a particular problem, as Deidre Sully said, for African Americans, where you have 85% of African Americans using menthol cigarettes. What about other groups? Hispanics are at about 45%. Asian Americans are also at about 45%. And youth, more so than older adults, start with menthol cigarettes. And menthol is absolutely the cigarette industry, and I call the cigarette industry the devil when it comes to these things. The cigarette industry has figured out how to potentiate the amount of nicotine delivered in a cigarette product by playing games with filters, by adding ammonia, basically causing us to freebase the nicotine at a much higher level. But menthol in particular makes it very, very difficult to quit. It's much harder for African Americans who are using menthol cigarettes to quit. So even though, if we look at younger people, African Americans don't smoke cigarettes at a higher rate than whites at a much higher rate, but it is harder for African Americans to quit. And so by the time they're in their 20s, 30s, and 40s, African Americans and whites smoke at the same rate, even though African Americans have started later. I don't know where exactly the current crisis is going in terms of reducing cigarette sales and vaping sales, but particularly for vaping shops. And if you go throughout Washington Heights Inwood, where my services are located on the Columbia University West Campus, New York Presbyterian, there are so many vaping shops. Every month, another vaping shop is opening up. They're selling vaping products, tobacco products. And this quote at the bottom comes from one of the big vaping vendors in Washington Heights. And here it is. As of now, all of our locations are limited to shipping and curbside delivery with only pickup at some locations on specific days. You must schedule pickup in advance. Please plan to have at least a week worth of supplies, as pickup and shipping delivery is limited to 2 or 3 times a week. So one of the things that is really, really important is cutting down on the ability to buy vaping products online, that convenience, especially for younger people. Really need to cut back on that, and we need to heavily regulate vaping shops to remove the ease with which younger people are picking up these products. So in summary, smoking is something that we have to cut back on, and vaping cut back on during the COVID epidemic, but we have services available. We have tobacco cessation services available at New York Presbyterian, and the other partners in this cancer network also have tobacco cessation services available. So we need to have our patients avail themselves of this, and we need to use the opportunity of the COVID pandemic to get patients to quit now. Thank you.
Thank you so much, Dr. Albert. And I didn't want to interrupt in the middle of your presentation, but I do know that a number of people wanted to cheer for the essential workers. So if you do need to step away, we will take a very brief break, and we have one more speaker. Dr. Albert, we have a few questions on vaping for you. We will do that in the final question and answer period, if that's okay, and take a very brief break now. We have one last panelist, Dr. Whiteson. So if we can reconvene in 5 minutes, that would be great. And if others want to put in questions in the Q&A, I'm sorry, I've been saying the chat box, but it's in the Q&A section. We can answer those questions when we come back.
All right, thank you so much for bearing with us. So thank you so much, Dr. Albert. And now we're going to move on to Dr. Jonathon Whiteson from NYU Langone Health, who's the Director of Cardiac and Pulmonary Rehabilitation and at the Wellness Program at the Rusk Institute. Jonathon, are you ready to go?
I believe so. So long as you can hear me and see my screen, I'm ready.
Yes, we can see you. Thank you.
All right. Well, first of all, I want to thank you for inviting me. It's really an honor and a pleasure to be a part of this panel and have members of the New York City community listen. And we take that very much to heart because we know the information that we share today is taken into your hearts, and that's where it really goes from our heart to your heart. And we care how you're doing through this difficult time in our city and our state, and certainly in our country. I guess I'm a long-term visitor, but I'm applying for my citizenship, so you'll be proud of me. I'm here 26 years. It's taken me some time, but I'm waiting, and the COVID pandemic put that on hold. I was hoping to vote at the upcoming November elections, but we'll see what happens. Anyway, as introduced, I'm one of the associate professors of rehabilitation medicine. Makes me a physiatrist, a rehabilitation doctor. I specialize in taking care of people who are functionally limited. In my area of specialty is people who are limited by heart and lung disease. And of course, many people develop heart and lung disease because they have, or because they've been smokers. So I am also a certified tobacco cessation specialist and have spent the better part of the last 10 years counseling people to quit smoking, as well as my other regular work. And today I want to answer 5 questions. These are they. What are the functional deficits seen with COVID-19 infection? What are breathing exercises and can they help lung health? What is pulmonary rehabilitation and who might benefit from it? Can tobacco cessation counseling continue during the COVID-19 pandemic? And then we'll finish off by answering the question, what is meant by exercise is medicine? So what are the functional deficits seen with COVID-19 infection? Well, before we can get to the functional limitations or deficits, we really need to understand what organ systems COVID-19, that virus, is infecting and affecting. And we've talked a lot about the lungs, and of course that seems to be the primary area where the virus gains access to our body through breath into our respiratory tree, deep into our lungs. Can also come in through the eyes too. Any of our mucous membranes can, the virus can attach to, but most commonly it's the lungs, and that's where we see the majority of people presenting, as was mentioned before, with a sense of shortness of breath because the virus impacts the lung tissue and creates a lot of inflammation. And inflammation in the lung tissue produces thickening of the lung tissue and fluid that's released, and it makes it very difficult for oxygen, which is the primary gas that we breathe, to allow our bodily processes to continue, and for our cells to make energy, we need oxygen. And if the surface of the lung is thickened by fibrosis and inflammation from a virus, then we can't get enough oxygen in. We also know that the virus is affecting the heart muscle, and some people are presenting with large heart attacks or small heart attacks, or definitely strain to the heart muscle where the heart muscle doesn't pump well. We also know our skeletal muscles, the muscles in our arms and our legs and our back, are also affected by COVID-19. And we see a lot of people with tremendous weakness. And you may have seen photographs in the press and online of people who lost 50, 60, 70 pounds of muscle. They have just become emaciated by being so sick from this virus. We also know that the virus gains access to the nervous tissue. When people talk about a loss of a sense of smell, that really relates to the virus invading the nerves at the back of the nose. And that's an access point for the virus to get into the brain. But certainly it does impact the brain, and we see some very significant changes in some people. And MRI studies of the brain can show very significant changes and signify significant brain dysfunction. We also know the brain is affected by clotting, by thrombosis. You may have heard of blood clots that are forming because of this virus, as well as the virus being very pro-inflammation. It is also pro-blood clotting. And we see a lot of people with blood clots that go off to the brain, and that's called a stroke. And we see, again, large vessel strokes as well as small vessel strokes. As well, these blood clots can go to the lungs and the heart and the kidneys and the gut and the skin. Hence, I put those organ systems down there as well, because we see a significant amount of kidney dysfunction, GI dysfunction, as well as liver and skin as well. So these are the varied organ systems that COVID-19 can infect and affect. And so what symptoms might people present with? Well, fatigue is probably the most common one, and generalized weakness, as well as shortness of breath. And sometimes that shortness of breath is at rest. Sometimes it's only when people are exerting themselves, where the muscles and the body needs more oxygen, but it cannot be supplied because the lungs are damaged. People often present with a cough as well. Many times that cough is dry, not necessarily wet like some other viruses or bacteria. And because we know the virus affects the brain, a lot of people have confusion, even to the point of delirium, the medical term we call encephalopathy, where the brain is overwhelmed and people cannot think straight. They lose memory, they lose focus and concentration, and become very agitated as well. Loss of appetite is also common, and along with that, weight loss. So understanding the organs and the symptoms, we can really understand the functional limitations, which in very severely affected people can be everything. People who are so impacted by this virus and are in the hospital really become essentially bedbound. It is so difficult for them to stand, for them to have balance, for them even to move in bed. The thought of lifting one's hand to brush your hair or to scratch your neck, it is just overwhelming and too challenging. And those people who are not so impacted, even people who have not been admitted into the hospital, many of them have such fatigue and such weakness, they're having a hard time washing and dressing themselves. Walking is impaired. The very thought of climbing the stairs is a near impossibility. Some people talking is too effortful. And many people who have been in the hospital have actually been on ventilators. Talking and even swallowing can be severely impacted. And then the cognitive functions. Sometimes we need to know how to sign our names, or to receive the right change when we've gone to a store, or to remember a recipe if we're cooking. So the cognitive deficits are also very significant. And of course, as the senator mentioned, he's an exercise fan, and we should all be exercising. But imagine feeling so weak and so limited trying to exercise. So clearly exercise is difficult, and this all relates to an impaired quality of life. Some people, they're affected minimally. Some people are even asymptomatic with COVID-19, but those people who are symptomatic can have a very difficult time, and their quality of life can be significantly impacted. So what are breathing exercises, and how can they help lung health, and is that relevant here? Well, I think we've all discussed smoking in general, vaping in general. We know that impacts our lung function, and we know that COVID affects our lung function. We've talked that that's the most common entry point of this virus into our body. So breathing exercises can help our lung function and are prescribed, not just for patients with COVID-19 in the hospital or out of the hospital, but also for people who smoke and have smoking-related lung diseases. I'm sure those are well known to many of you. Often we call it COPD, chronic obstructive pulmonary disease, of which emphysema and chronic bronchitis are the two commonly used terms to describe the pathology or the disease state that's associated with smoking. And breathing exercises are really, really important to improve lung health and to improve overall function. And why? It's because they help open up the airways, clear the secretions out of our airways, and improve oxygenation. So one of the most simple breathing exercises we can do is deep breathing exercises. In order to be able to do successful deep breathing exercises, we have to maintain good posture. We cannot be hunched forward. We have to sit up nice and straight so that we have a straight back and we can allow our chest the ability to fully expand. Some of you may have heard of a gadget, a pulmonary tool called an incentive spirometer. And that is something that is held, and people take deep breaths through a mouthpiece and may watch 3 little balls rise into the air or a bobbin that rises up as they breathe deeply. It really gives a visual feedback to deep breathing exercises. The value of deep breathing, again, it expands the lungs. It can induce coughing, which is a good thing. Coughing is protective to our lungs. It helps to clear mucus out. It's part of a normal mechanism of secretion clearance or any inhaled kind of foreign object. When we cough, it is protective to our lung tissue. So deep breathing exercises through an incentive spirometer, or if you don't have one, just sitting up straight and taking in the deepest breath you can take and repeating that 3 or 4 times really helps to improve secretion clearance and oxygenation. And that takes us nicely into the secretion clearing exercises. Again, some people and those with COVID may have a dry cough, but many people with smoking-related lung disease, especially chronic bronchitis, will have a wet cough. That wetness comes from mucus that's produced by the cells deep in the lung tissue. And we all produce mucus. We all clear our throats and cough a little. But those people who smoke have an excessive amount of mucus. And if we can't clear that mucus, the mucus can dry, it can plug or block the airways. So it's really, really important that we do breathing exercises to clear the secretions. And there are various different gadgets and tools that can be prescribed and used. The lung flute, the acapella, the aerobica, different machines that you can be taught how to use them. And using these different gadgets, it produces a wave of vibration down through the airways. The air vibrates the airways and helps to shake those airways and encourage secretion clearance. So those are very, very important, sometimes used with changing position, lying down, lying on one side, lying on one's stomach, allows the different areas of the lungs to drain of mucus while doing secretion clearance exercises. Pursed lips breathing is another exercise that we teach, especially for people with emphysema. In emphysema, it's not uncommon for the airways to be so damaged that as we breathe out, those airways collapse down and causing air trapping. When we breathe with pursed lips, it's almost like you're blowing a kiss, puckering your lips, breathing out slowly against resistance against your closed lips, or should I say pursed lips, not closed, but pursed. And that produces some back pressure, believe it or not, mechanically down through the airway and prevents the collapse of those airways and allows us to clear all the waste gas out and allows us to take in a deep breath of pure oxygen. So pursed lips breathing are also very, very important. And finally, diaphragmatic breathing, which is a technique that's not always easy to learn, but is effective. And it allows us to increase the excursion of our diaphragm, our major breathing muscle. And this is a difficult one, and I can't go into too much detail because it would take me too long. But essentially, when you breathe in, instead of your chest rising, it is actually your belly that moves out, and that allows the diaphragm to drop. And when you breathe out, the belly falls back down again, pushing the diaphragm up and helping you to breathe out. And you can look on YouTube, and there are many videos that show how to do all these different kinds of breathing exercises. Very much worth it to improve your lung health. What about pulmonary rehabilitation and who might benefit from it? Well, I'm going to start by saying that anyone who is limited by lung disease, limited functionally, can benefit from pulmonary rehabilitation. And because we've been discussing healthcare disparities, there are some very clear healthcare disparities in those people who are and are not referred for pulmonary rehabilitation. And unfortunately but true, African Americans and women are the most poorly referred for pulmonary rehabilitation. But we know that once referred, they benefit just as much as anyone else who's referred for pulmonary rehab. And this is something that is one of my missions in my career and in my work, to make sure that enough people are referred through who require, irrespective of gender or racial background. But we really have to work hard to improve the referral rates for women and African Americans. Pulmonary rehabilitation is a combination of 4 components: exercises, nutrition, emotional support, and education. The exercises, I'll break it down as well into 4. They are breathing exercises I've just discussed, postural exercises to make sure that we are allowing our chest to expand properly by correct posture, general strengthening exercises to make sure we have enough strength, and aerobic conditioning, by getting people on a treadmill or a bicycle to help improve their endurance. It's challenging for people who are short of breath, even at rest, to say, okay, let's walk you, let's get you climbing stairs, let's get you exercising. But it is really very, very key to do that. Nutritional support as well is very important. People with lung disease can often present with wasting, muscle thinning because of difficulty eating, and so nutritional elements need to be approached. Emotional support, because this is so challenging, it's so limiting. People with advanced lung disease from smoking, whether it's COPD, perhaps even cancer, or lung surgery from cancer, they need a lot of emotional support. They become very socially isolated and scared. And education, to teach people exactly how to live a healthy lifestyle. So who can benefit? As I said, just about anyone who's limited. COPD, which includes the emphysema and chronic bronchitis, people with lung fibrosis, people with COVID-19 lung disease, people who've had lung surgery for whatever reason, including cancer, and people who've had lung transplantation and other lung reduction surgeries. My 4th question, can tobacco cessation counseling continue during the COVID-19 pandemic? Absolutely yes. And as was mentioned before, telehealth is really an incredible opportunity for us to reach more people who, for whatever reason, geography or debility, could not get to the doctor's office. Here we have an opportunity, and we believe this is not going to go away. We believe that telehealth is here to stay. That really allows us to do video conferencing and tobacco cessation counseling through a video conference. And you know, there's always been the state quit line, 1-800-QUIT-NOW, which is a telephone service that also encourages and allows tobacco cessation counseling. So I have spent a lot of time during this pandemic counseling my patients. I've actually had more time because much of my face-to-face business has gone away, although it's coming back now. But it has provided me a lot of time to counsel people face-to-face. And I've had 4 or 5 people during this past 2 or 3 months who have successfully quit through video conferencing, this telehealth tobacco cessation counseling. And as we're recognizing and seeing the pandemic is slowly improving in our city, we have now resumed at NYU, and I'm sure many of the other health centers and medical centers in New York City, we're resuming face-to-face visits. So there's no time like the present. There's no such thing as a safe puff. If you're a smoker, today is the day we should start your tobacco cessation program. And the final question which I wanted to answer, which is, what is meant by exercise as medicine? And these are pretty bold statements, but it's borne out epidemiologically, and there's a lot of research to support this, that exercise can prevent disease. If we look at a general population and we look at how much exercise people do, we see that those who exercise more than those who exercise less or are sedentary have lower rates of cardiovascular disease like heart attacks and strokes, lower rates of cancers of nearly every single organ, and generally have a longer life and a longer disease-free life. So exercise really can prevent disease, and the biology of that prevention is well elucidated. Can exercise help overcome functional limitations to disease? Well, of course, yes, it can. That's the world of rehabilitation. In my world of heart and lung rehabilitation, that's what I do every single day, helping people who are limited by advanced heart or lung disease overcome their functional limitations and realize that they can go from weakness to strength and from strength to quality of life. And exercise can cure disease as well. Absolutely. We see, even in cancer, that exercise is really the fourth arm of treatment. If we think of surgery to remove the cancer, radiation therapy, chemotherapy, exercise should be considered as the fourth arm of treatment. And in many forms of cancer, exercise really can impact the biology of the disease to enhance the cure rates and also enhance the compliance with treatments. There's good evidence that suggests that exercise really does help support people when they're going through chemotherapy. So just in brief, any activity is better than nothing. More is better than anything. The type, the duration, and the intensity do count. Aerobic exercise is really key, and that's what induces many of the positive changes to help prevent and cure disease. Strength is also important too. Duration, at least 150 minutes a week, and ideally 300 minutes or 5 hours, which means 1 hour, 5 days a week. And the intensity, again, at least 1/3 of your exercise should be moderate intensity. Moderate intensity means it feels moderately hard. I have to focus and stay in tune to keep exercising at that intensity. And remember, and my last words, exercise is lifelong for a long life. I want to thank you. I'm happy if anyone wants to send me emails and communicate, and always happy to give guidance and advice. And I'm willing and prepared to take any questions that may be thrown my way.
Wonderful. Thank you so much, Dr. Whiteson. And in the interest of time, do you mind if we open now the questions to the entire panel?
Of course, that's fine.
That was fantastic. I was also hoping if you'd be willing, if you could share, I know you mentioned a lot of those breathing exercises are on YouTube, but if you have some favorite YouTube instructors or links, if you could send them to us, we can send them to the participants, because I think you were saying that these breathing exercises can help all people, whether or not that they're currently smoking. So it sounds like those would be useful exercises if you wouldn't mind sharing your favorite links.
Absolutely, we can do that for sure.
Great, thank you. Okay, so we have a lot of questions. I was wondering if all the panelists could come back on. And I will just read the first question, and then Kim, if you'd like to read the second question. So I'm just working from the bottom. What is your thought on any negative effects of using a face covering, especially for those who have poor blood gas exchanges, that they are rebreathing their CO2 exhalation and at risk of carbon dioxide toxicity? Okay, that's a fairly specific question, but an important question. So if any of the panelists would like to specifically answer that question, are there any negative effects of using a face covering if for people who are having poor blood gas exchange ability?
So I'm happy to start off with that, and others I'm sure will have some thoughts. And it is an interesting question. There are different kinds of masks, of course, but the masks all do allow adequate gas exchange, both getting oxygen in and carbon dioxide out. So I have seen no evidence of worsening carbon dioxide retention in people who are prone to that. And again, people with COPD, especially chronic bronchitis, may be prone to retaining carbon dioxide, and retention of carbon dioxide is a toxin. It impedes our breathing drive. and also our brain function. So it is a dangerous situation. There is evidence that shows that people cannot tolerate as much exercise when they're wearing a mask. Again, that does vary with regards to the mask. There are some looser fitting face coverings, bandanas, which have been appropriate in the outdoor setting, and surgical masks, which are sort of loose around the face, which provide protection in terms of when you're breathing out, you're not spreading the virus, but do allow you to breathe comfortably. So no concern from my perspective using a face mask in terms of carbon dioxide retention, although we would expect and do see that people are less able to breathe comfortably when they're wearing a mask and trying to exercise.
Okay, great. And if I could ask a very quick follow-up question, as someone else asked recently, is there anything that you would change based on that advice for asthmatics?
No. Asthmatics in general are not at risk for carbon dioxide retention. That's not something we think about in asthmatics. Some specifically may be, but in general, no. And the same kind of response in terms of exercise with a mask. It does increase the work of breathing, but it will not induce bronchospasm, which is the tightness of the airways that we do see in people who are asthmatic.
Great, thank you.
And I'll just add, I think the only thing to keep in mind is to just use common sense. And obviously a lot of people are uncomfortable with a mask on. And I think if you're out and around, then there are times when you can take it off and get back to baseline. And the other thing with asthmatics or people with reactive airway disease is just to make sure your mask is clean. Obviously these masks can collect a bunch of stuff and get pretty gunky and junky. And I think that can probably increase the airway reactivity. So just frequent cleaning of the mask or switching out masks is important.
Great, thank you, Dr. Stiles. And Deidre Sully, who's the director of NYC Smokefree. I was wondering, there's a number of vaping questions. If you could start us off, and then Dr. Alberts, if you could respond after Deidre too, about how do we prevent a lot of the high school kids from vaping, and then there's some vaping and COVID questions that we wanted to ask you right after that.
Well, education is my, top answer. And the way that we do that at NYC Smokefree, we actually have a two-pronged approach to our work in general. And one is very community engagement oriented, and the other one's youth engagement. And that's specifically through our reality check program. So we work in all 5 boroughs with youth engagement managers that go into schools. They work with youth serving organizations, and they work to try to encourage young people in high school or ages 12 to 18 to join reality check. And it really is our youth action arm for tobacco control. And that's getting young people excited about tobacco control advocacy. It also allows skill building in a lot of other places. So public speaking, on the issue, educating their peers, learning how to write opinion pieces in papers. So education is the key, no matter what, whether we're dealing with young people, adolescents, or adults. It's really education. And we start by working with young people between 12 and 18, directly in the schools, and we're meeting them where they're at.
Great, fantastic. I know you do so much. It's fantastic. Would you also be able to respond to this question, and also Dr. Albert, about secondhand vaping? Is it as dangerous as secondhand smoking?
I'll stay with that one. So secondhand vaping is a problem. It is not as big a problem as secondhand smoke, because the combustible and the amount of things that are thrown up into the air from a combustible are much, much more than from vaping. But vaping, secondhand vaping products that are inhaled are just a significant problem as well, but not quite as much as it is for smoking. But we want to eliminate all these products from the air inside our homes, and where especially young people and people who have breathing difficulties. So vaping is a problem, secondhand vaping is a problem, but not as much as combusted tobacco.
Next question, sorry to interrupt. Our next question is, are there any treatment options for those who vape?
I will give some information. So right now in New York State Tobacco Control Program does have a program specifically for young people where they can hashtag drop the vape in their phones. You can go on our Instagram page and find information on that. Instagram, as it's just at NYC Smokefree, and you text drop the vape to a specific number, and it basically is quit help for young people who have become addicted to vaping.
Yeah, I also want to point out that the evidence base, this 5 A's, ask, advise, assess, assist, and arrange, was developed for tobacco smoking and as well as smokeless tobacco. It was not designed for vaping, but there are research projects working to see which components or how to modify the 5 A's so that we could use it for vaping. And what Dr. Whiteson mentioned earlier about the Certified Tobacco Treatment Specialist Program, the vaping is now starting to become a component of those programs. I'm also a certified tobacco treatment specialist, and I want to put a plug in for MSK's, for Memorial Sloan Kettering's program, which is going to be running in mid-June. So if you're interested in becoming a certified tobacco treatment specialist, go online and take a look at MSK's program, which will be virtual this time.
Okay, thank you so much. So another question that we had that came in before the panel was, in general about COVID-19, it appears that men have a higher infection rate than women. Why is that?
Well, it's a tough question. I'll take a stab at it. I think certainly in our series and in those of others that have been published, we've seen higher rates in men. It's unknown of whether that's secondary factors or whether they engage in more high-risk activity. You know, they're out and about. They're often in many cultures, they're often the ones who are out working and leaving the home and engaging in more high-risk activity. I certainly think that that has a lot to do with it. We've certainly noticed that in our patient populations, they tend to have more of the comorbidities that have been associated with COVID infection as well. I'm still not aware of the direct data. You know, there's some suggestion of possibly a hormonal protective role, but I'm just not as aware of the data on that.
Yeah, I think that data is starting to emerge and be discussed, and certainly our estrogens protective and the testosterone promote risk. So there may be some true gender differences in terms of biology, but that, as you said, that data is just not firm at this time, but it's being looked at.
Thank you. I think a number of you already touched on this throughout your presentations, but what advice would you give a person that's been smoking for almost 40 years and has heart problems and can't stop smoking? What should they do vis-a-vis COVID-19? And I know a number of you talked about this, but specifically, what are things they can be thinking about?
Well, I'll take a stab at the first part as far as resources to quit. We do make sure that that information is on our website. So you can go to www.nycsmokefree.org/quitting. And there's a number of different resources that New Yorkers can try. One in particular, each borough, and this is information that you can also find on New York City Healthy Hospitals. Each borough has hospitals, a part of the NYC Healthy Hospitals Network, that do provide cessation services. Some are free to a nominal fee, and they list the type of services they provide, from person-to-person counseling, group counseling, to nicotine replacement therapy. So I encourage you to look through some of those resources for help quitting. As Dr. Albert said on the phone, you know, on the line, there are, you know, programs that do help people quit.
Yeah, and I'll answer too. I think that Deidre makes some great points. Those are all really important. I think it's tough for somebody who's been smoking for 40 years to realistically think that they're going to quit with all these things going on and really understand that. And so I think it goes to some of the other things about asking for support, asking for help. It's a good time to sort of probably pause and reflect upon it and make a plan, whether that plan gets started now or is sort of put in place. There's plenty of resources out there. You can hear from this, and I think that is key right now to think about. In the interim, just concentrate on protecting yourself and doing all the things that people are asking you to do. I think about distancing and about masks and hand washing. recognizing that it's a very hard thing to quit. And I think we sometimes unfairly stigmatize or put too much pressure on people about quitting and how it's just a choice. We know that it's an addiction. And so I think all these resources that Deidre and everybody else have spoken about, it's important just to reflect upon that and reflect upon the disease and not put too much pressure on an individual, on him or herself in this situation.
Right. I'll also add, you know, individuals can also speak with their doctors. You know, we are in a really crazy time now, and you know, it may be difficult to get an appointment. You know, I'm not sure what individual situations are, but we also encourage people to talk to your doctor. You know, one of our tobacco control counterparts in the health systems arena, that's what they actually do, is work with providers and helping them to change health systems to talk to patients to include quit resources and quit help for people.
Thank you. And Deidre, while you're follow-up question to the secondhand smoke question, you raised a lot of important issues for people who are sheltering in place about exposure. So there's a question about secondary smoke exposure related to COVID-19 infection. Again, people during this situation do not have a lot of choices in terms of getting away from secondhand smoke while they're sheltering. What can they do to at least reduce some of their exposure?
So that's where we come in. You know, we're happy to speak with residents and try to hear their stories. And if they're comfortable with us contacting their landlords or boards, you know, depending if you live in market rate, affordable or condo co-op, we're happy to reach out to those entities, you know, do presentations, a virtual presentation in these times with the board, and really go through some education on why smoke-free housing is a really great option. You know, we are seeing things in the news. There was a New York Post article, like a woman was chain smoking in her apartment and it caused a lawsuit. And unfortunately, it did not end up well for the actual, for the property manager. And that's why we want to work with people before we have these situations, so we can talk to them about, you know, adopting voluntary policies and putting them in their leases, you know, so that they, you know, are something that they can actually stand behind.
Great.
So I would ask the person to please, you know, depending on the borough that you live in, you can reach out to the specific borough office and we can take it from there.
Great. Thank you so much. And there's a lot of great information in your slides and all the panelists. There was someone that wrote in to ask about the slide presentation. And yes, we have been recording this and we'll share slides with the permission of all the speakers, as well as all of the resources and emails and things like that in terms of how you find out about some of these programs. Kim, do you want to read one of the questions that was written in?
Sure. This question was partially answered in the chat box, but it was a question about, you know, how important would it be for someone to quit vaping versus quitting smoking, and what would their risk of vaping 1 to 3 days a week be as opposed to every day, and how long should the bridge last while vaping to totally quitting nicotine?
Those are all pretty specific questions that are tough, I think, for a panel to answer, not knowing the person. I think certainly most of us probably think that in some heavy smokers that e-cigarettes can be a bridge to cessation. And I think there's some encouraging data that shows that the quit rate in one randomized trial at least is almost twice as high. That said, the quit rate is still less than 20%. And so you can't quit just with vaping. I think that's a big misconception. And I think you need all the resources that the panel presented here. I think the other thing to think about is that in those patients who did quit with e-cigarettes, many are still dependent upon nicotine, and many are still using the vaping products long after people have already stopped other cessation devices, those who maintain the ability to quit. And so, you know, the trade-off is quite challenging sometimes between vaping and other methods of quitting tobacco. And that's really where I think you have to take a little bit more of a team approach rather than just saying you're going to do that to quit. That said, I think certainly for some patients who are heavier smokers, it may be a bridge to quitting. The specifics about how many a day and how you do it is going to be very individualized.
And I would also add, you know, to just for folks to remember, like generally, vaping e-cigs are not FDA approved quit devices. And this is why we really hammer home, you know, looking into the resources that are there and FDA approved quit help. And that's specifically because, you know, the vaping and the e-cigs, they are electronic nicotine delivery systems. Their sole purpose is to deliver nicotine. So we want to be careful of, you know, talking about, you know, vaping and quitting. And of course, anecdotally, we have heard that some people have been able to quit, and that's awesome, because that's what we ultimately want, is for people to kick the habit of nicotine. But we have to remember that it's not an FDA approved device, and the studies are still out on that.
I just want to add one thing to the discussion. The person using it 3 days a week, I mean, we emphasize getting patients to quit and setting a quit date, but harm reduction is also important. And if you can cut back that person who's using it 3 days a week to 2 days a week to 1 day a week, that's a success as well.
Yeah, I agree with that. There's no doubt that the tobacco and e-cigarette use, I mean, the harm is a dose-response relationship. The higher the dose, the greater the risk, and the lower the dose, the lower the risk. So 2-3 times a week, should I say, is better than daily. I think we have to be very cautious about e-cigarettes. My personal perspective is that it is up to the e-cigarette industry to prove their safety rather than for us to prove that they're not harmful. And when any kind of drug comes to market, the drug company really has to prove that that product is safe through multiple levels of testing. And that's just not been done with e-cigarettes. So I personally do not use e-cigarettes or encourage anyone to use e-cigarettes when it comes to a tobacco cessation tool. I agree with Deidre that there are FDA-approved products which are tried and tested, both all the nicotine replacement products and Chantix and Wellbutrin or Zyban have been FDA-approved and tried and tested, and e-cigarettes have not. So I think we have to be very, very cautious and not give the impression that an e-cigarette is an approved way to quit smoking. And don't forget that this battery-operated vaporization of nicotine, it's not just nicotine that you're getting, it's many other chemicals as well. And as I think was discussed by Dr. Albert, that these can be carcinogenic. And we have to be very, very cautious about encouraging people to use them. So again, FDA-approved products, from my perspective, should be the way to go.
Wonderful, thank you. And another question just came in. It is, can lozenges for quitting cause cancer?
No. Nicotine lozenges. So nicotine lozenges come in 2 sizes, 2 milligrams of nicotine and 4 milligrams of nicotine. Same way that nicotine gum and nicotine replacement therapy, you know, is all using nicotine. And nicotine, the amount of nicotine that's being used is less than what you're receiving from smoking. So you're actually decreasing the risk, not increasing the risk. So lozenges are safe.
It's not
Great.
nicotine that's carcinogenic. It's the thousands of carcinogens in the combusted tobacco that's carcinogenic. So nicotine itself, so nicotine replacement is safe when you use an FDA-approved product. Because nicotine does not cause cancer. It doesn't have those chemicals. So again, that just goes to support the nicotine replacement products that are FDA approved.
Yeah, and that's an important point. We didn't discuss upon it tonight, but I know a number of colleagues at Columbia are doing research specifically on vaping products, because you do get heavy metal exposure. So sometimes people think that vaping products may be safer, but you still do get exposed to metals, which are carcinogens. I have another question that just came in. And again, we're just in the last few minutes. So if you have any more questions, please do type them into the question and answer. Can you take medications that are FDA approved to be used by a person with heart disease? Can you take those medications? Oh, I think the medications that you were referring to, Dr. Albert.
Yeah, so a patient with heart disease depends on what kind of heart disease the patient's had. But pretty much the principal area where you would have caution in using nicotine replacement therapy would be immediately after a myocardial infarction. Other than that, if somebody has their blood pressure reasonably controlled, it's fine to be using nicotine replacement therapy.
Thank you. And while we're just waiting in case there's one or two more questions, Dr. Whiteson, you had mentioned in your presentation that there's lung rehabilitation therapy that's just as effective in women and Black individuals, and but you said they don't get referred to that kind of therapy, but the data suggests that all people benefit. What do you think could be done to make sure that the referral patterns are more equal?
It's a great question, and that's why I'm sitting on this panel tonight. If I can speak to 50 or 60 community members, and they can go and tell their community friends, brothers, sisters, church members, etc., that pulmonary rehabilitation can help them, we have to spread the word. So educating the consumers of these services so that they know to go and ask their physicians for a referral. Educating the physicians as well. Many physicians don't realize, don't know how to refer, that these programs exist and are very effective and very helpful. And then there's some legislative work that we need to do as well. Pulmonary rehab is reimbursed very poorly, and in a freestanding setting, pulmonary rehabilitation is not a financially viable situation. So there are very few pulmonary rehab centers. So the accessibility, the availability of this specialized therapy is limited because it does not pay on the business model. At NYU, at Rusk Rehabilitation, we're very fortunate to have an administration that, even though our program does not make money on the day, it absolutely supports the mission of the medical center to keep people healthy, and actually helps reduce readmissions into the hospital following admission for COPD exacerbation. And in fact, in the city, we get patients from all over all the Manhattan major hospitals send us their patients because they recognize the value of pulmonary rehabilitation. So it's up to me to spread the word, and it's up to those people who hear that word to spread it on. We need to educate the providers, we need to educate the consumers, and we need to lobby at the government level as well. Great.
Maybe that's something, Senator Jackson, we should ask for his help. I know he's been very helpful with the menthol legislation.
I would love that.
Great. So in the interest of time, Kim, maybe do you want to do the very last question? And then I want to ask each panelist or give each panelist an opportunity to say a few last words. So there's one last question, Kim.
Yeah, the last question that has come in is there any help for someone who is addicted to hookah?
I think the same applies. Like, it's really, hookah is really interesting because there was a big craze at one point, you know, hookah restaurants all around. But I believe in October 2017, New York City did pass legislation basically reducing the hookah establishments to those where they're, you know, most of their business is hookah. So if you're a restaurant and you're just, you know, you just kind of have hookah as like an added amenity, you can't do that anymore. The tricky part is a lot of these places were advertising them as non-nicotine or non-tobacco shisha, when in fact a study was done, like a sting operation was done, and they lab tested a lot of these things, and they found that they actually did have nicotine. So it may not be like you're addicted to hookah, it's the nicotine that's the addictive agent. So I would, you know, imagine the same would apply with, you know, getting cessation help from a lot of the resources that were mentioned today.
Great, thank you so much. And then again, we've had a lot of great feedback from the people who have participated, thanking all of you. I'd also like to extend my thanks and to the entire team and all of the collaborators that have worked with us to plan these events all week long. We will have 2 more webinars, and please do check out the website because there'll be lots of resources. So just to end with giving each panelist a few last words. So start with you, Dr. Stiles.
Well, just thanks for having me. It was a great discussion. I learned a lot from all the other panelists. I'll put one more plug in for lung cancer screening. We just talked about it a little bit. But if you're in the right age group and if you've smoked, please ask your doctor about lung cancer screening. It's grossly underutilized, and in particular among minority patients. We know that we can do it well, and there's plenty of resources out there. It's also a great opportunity with the shared decision making to start talking about smoking cessation.
Great, thank you. Deirdre Sully?
I would say now more than ever, as we're dealing with this pandemic, now more than ever it's the best time to quit and to speak with your physicians, look into the resources that are there. And definitely, I'll also put in a shameless plug, please visit our website at www.nycsmokefree.org. And we have a lot of information on the work that we do and the initiative areas that we focus on within tobacco control.
It's not shameless at all. We really appreciate all that you do, especially with the young kids. And it sounds like you'll get a lot of volunteers from this call, already people writing in. So thank you so much. And Dr. Albert?
Yeah, thank you for putting together this conversation. I think when we have crises, sometimes what comes out of the crises are things that we couldn't have been able to do in 10 years. And telehealth is one of those things that I think is remarkable. And so I think it is a lot easier to get access to tobacco cessation services now during the COVID crisis and hopefully after the COVID crisis. And it's important for us to make sure that we utilize insurance programs that cover this. The Medicare program covers it, the Medicaid program covers this, and many private insurances cover tobacco cessation counseling. So take advantage of it.
Great, thank you so much. And Dr. Whiteson?
I want to thank you, obviously, for inviting me. I've really learned a lot as well from the other panelists, and I congratulate them all for their work. And thank you to the attendees who spent close to 2 hours listening to us. Remember, life's a journey. Exercise through it. Exercise is medicine. It saves your life. It improves the quality of your life. And it's applicable to you as it is to everyone else. Do a little bit more today than you did yesterday, and a little bit more tomorrow than you do today. And that's the path to take.
Thank you so much, everyone. And you will be receiving, for the participants, an exit survey. We would love it if you wouldn't mind filling it out, as that helps us in planning new events. And really appreciate everybody's time tonight during these very challenging times. And thank you again to all the panelists, as well as to all the organizers. And we look forward to speaking with you again.
We just have an exit poll, if you don't mind filling that out, for all the attendees. Thank you so much for joining us, and we appreciate your time.
Okay, the exit poll is just on screen then, right?
Yes, it's on the screen.
Okay, perfect. So before you leave Zoom, thank you again, everyone.
Thank you so much, everyone, for joining. I'm going to leave the quit line up here. And also, we do have 2 more webinars this week, which are smoking cessation, another panel discussion and Q&A, which will be Wednesday, June 3rd from 6 to 8 p.m. We also have our website up here, nycnotobaccoweek.wp.com. And we have a Spanish cessation webinar where we'll be talking about the harms of tobacco on Thursday evening this week from 6 to 8 p.m. Thank you so much for joining and have a good evening.